some therapeutic possibilities which should be pursued definitely. So this is the case, 85 years old female. She had cataract surgery in her left eye, and unfortunately she has age-related macular degeneration in both eyes. And despite the numerous injections with anti-VEGF in the left eye, the vision in that eye is particularly poor. She has counting fingers. Luckily enough, she is a very active person, and she has very good vision in the right eye, although she has some early signs of age-related macular degeneration. And this is the situation. Left eye, late stages of the disease with a lot of fibrosis and atrophy of the macula. And the left eye 2025, we might suspect that there is a plaque here as seen as with indocyanine green angiography. But the situation is relatively stable. She has a flat PED, but again, good visual acuity. So she comes in immediately after she had some sudden visual loss, metamorphopsia in the right eye for 2 days. And the vision has dropped down to 2100. And this is the situation, as you can see here. A large and thick hemorrhage at the posterior pole. You see at the OCT retinal detachment with subretinal blood, very thick, very dense. And not only, she has also some elevation of the pigment epithelium with some blood underneath the retinal pigment epithelium. And I extensively talked with the patient, and I mentioned the possibility of surgery, specifically surgery and blood displacement with TPA. But she was really afraid that that was her only eye. She was really hoping that the hemorrhage could reabsorb spontaneously, and she didn't want to undergo any surgical procedure. So I was continuously following this patient 7 days, 2 weeks, and the visual acuity dropped down to 2400. So she came in spontaneously after 25 days, 2400, and she at that time she asked for surgery. Obviously, there are many options in these patients, waiting and seeing how the situation evolves. There is the possibility to inject TPA either under the retina or into the vitreous cavity. Anti-VEGF injections are very often performed. You have other options, macular translocation, but I'm not a big fan of macular translocation. I would say that PDT has no role in these cases, and also pneumatic displacement without an injection has been suggested. So this is the case that we brought her to the operating room, 27 gauge vitrectomy, removing the central vitreous, then some staining with a triamcinolone for detaching the hyalod, fully detaching the hyalod. And then we going with this 41 gauge needle, and we find out the proper location for injecting TPA subretinal, which you will see in 1 second. You will see the bubble enlarging and detaching the neural retina at the posterior pole. At the end of the procedure, the whole posterior pole has been detached by the fluid injection. And at the end of the procedure, there is this fluid-air exchange. And finally, before finishing the case, I inject anti-VEGF into the vitreous cavity. So this is the follow-up of this patient. This is 15 days later. Visual acuity is still 2400s, but there is some recovery of the retinal, central retinal, as you can see here, less pigment epithelium detachment. The hemorrhage is less dense, has gone inferiorly. Unfortunately, it was quite a late hemorrhage, and she has some changes with some initial fibrosis during the course of the follow-up. And this is 3 months. The hemorrhage is almost fully reabsorbed. Visual acuity goes back to 2032 with a nice foveal contour. This is the situation at 1 month with OCT angiography. I think we could detect some feeder vessels. And this is the follow-up farther. At 12 months, the patient is very happy, 2032, a very nice OCT foveal contour. There is some fibrotic changes outside the very central fovea, and that's why the situation is very impressive. During the course of the follow-up, the patient did receive 1 single injection of anti-VEGF after vitrectomy. If you go into literature, you find some publications. Some of them are positives in the outcomes, because with surgery you can displace the subretinal hemorrhage in the majority of cases. You can also have some improvement in visual acuity. And also patients who do receive vitrectomy and TPA injection, they finally have a reduction in the final scar area. And this is very important for the residual visual acuity. There are also some negative reports, mostly due to the possibility of rebleeding. The rebleeding incidence goes up to almost 30%. And also some authors speculate that the improvement in visual acuity might usually be very modest. This is the mostly used TPA dosage, 0.1 to 0.4 ml under the retina, and this is the dosage 12.5 micrograms in 0.1 ml. The timing for surgery, this is a point of discussion. As early as possible, I would say. This is what you find in literature, in between 15 days to many months. Obviously, I don't advocate to do surgery after 3 months after the subretinal hemorrhage. If you're gonna see something deeper and have some ideas on how we should deal with those patients, we came out with some consensus recommendations on management of subfoveal hemorrhage with the Vision Academy, and you find this viewpoint in the website of the Vision Academy. So the final message is, when you see a patient, especially a single eye patient with a thick and large hemorrhage, don't leave the patient alone. Try this possibility, vitrectomy, subretinal TPA, and anti-VEGF at the end of the surgery after a fluid gas exchange, and you might end up with some good results in many patients. Thank you very much for your attention.
Can I say something?
You are muted, sir.
Can I say something?
Dr. Abdullah, you are muted.
Hi.
You're still muted.
Yeah, thank you, Dr. Paolo, again for your very nice presentation and technique. I guess we have a few minutes for any comments from the panelists or the speakers.
I want to congratulate Paolo. Great case, impressive result after so many days after the hemorrhage. I have 2 questions. First, do you consider to leave air, as Tamer Mahmoud described some years ago, to leave air under the retina to displace more the blood? This is my first question. The second question is, do you try to see if there is only subretinal hemorrhage or subretinal and sub-RP, because the results are more difficult to establish? Do you try to know this, or you operate any single case that you have a subretinal hemorrhage?
Carlos, thank you very much. Those are great questions. As regards the role of air underneath the retina, yes, some authors suggest to inject air to further displace the hemorrhage. I don't usually do it on purpose. Sometimes I do inject a small amount of air because when we are preparing the syringe, some remnants of air are still into the syringe with the TPA. So when you are injecting, first you do inject some air and then the liquid part of the syringe comes out. And this might be helpful because the small amount of air under retina might avoid leakage of TPA into the vitreous cavity once you have the case. But again, I don't inject large amounts of air underneath the retina. As regards the subretinal or sub-RP hemorrhage, this is an excellent question. And I think that we are lucky enough to have the OCT imaging today. So all the patients should be imaged with OCT before bringing them to the OR, because if this hemorrhage is fully underneath the retinal pigment epithelium, there is no indications for doing such surgery. The case I brought, the lady had some part of the hemorrhage which was subretinal and a smaller part that was underneath the retinal pigment epithelium. And very luckily, the retinal pigment epithelium detachment resolved after surgery.
Thank you, Dr. Carlos, and thank you, Dr. Paulo. I think we have to keep moving. Back to Dr. Girdar, who is with us now. Please, Doctor.
Yes, sir. Yes, sir.
For the presentation.
Okay.
Nice to see you, Doctor.
Yeah, I am showing the theme of my presentation is posterior segment ocular trauma, and I am showing 3 short videos.
Can you share your screen, please?
Zone 3 posterior scleral rupture.
You can see my presentation?
Yes, you have enlarge and play.
And
yes,
maximize.
Now, if you can enlarge. Yes.
Can present as a silent scleral perforation, like in this particular patient. There is no discontinuity of the conjunctiva. Visual acuity was 6/6, and a wide-angle photograph shows a scleral rupture with a tear in the retina in the temporal periphery. The patient was taken up for surgery. I usually perform a 360-degree limbal peritomy. The reason I do that is we need to also look into the other quadrants to see whether there is any other damage. I then hook the superior and inferior rectus.
Girdar, we cannot hear the sound.
It becomes easy. Since this particular rupture is situated behind the lateral rectus, I am now disinserting the lateral rectus. For that, I place a mapped suture in the belly of the lateral rectus close to the insertion, and then place a clamp at the right of the insertion of the lateral rectus and cut the lateral rectus flush with the insertion. And the suture that I have placed acts as an identification mark to identify the muscle later. So once you have done this, the scleral rupture is exposed. This is, as you can see here, this is running perpendicular to the limbus posteriorly, and the whole scleral rupture, the whole extent of the scleral rupture has been exposed here. Regarding some of the tips for suturing a scleral rupture, I prefer a mattress suture. If you put a mattress suture, it gives very good apposition, and it sutures a large portion of the tear with one suture. Especially if the tear is ragged, it is advisable to use a mattress suture. In this particular case, I'm using 7-0 vicryl suture, and I'm using a combination of mattress and interrupted sutures. The key to management of such a case is basically the exposure of the full extent of the tear. Once you do that, then the suturing is not very difficult. The challenge is to expose that quadrant because it is inflamed, there is a lot of oozing and bleeding. In this particular case, since there was an associated retinal tear, I decided to put a segmental explant covering the region of the scleral rupture. So for that, I'm placing a mattress suture, one above and one below the lateral rectus. So this is the second mattress suture below the lateral rectus. Subsequently, I'm reinserting the lateral rectus at the site of the insertion. Already we have placed a pre-placed suture on the belly, which is now sutured onto the insertion, at the site of the insertion. I now pass the silicone explant under the mattress suture, under the lateral rectus, and again pass it to the inferior mattress suture. Subsequently, I tighten the sutures. The explant is probably an optional step in the management of this particular case. The conjunctiva is then closed, and this is the picture you can see 1 week after surgery.
Traumatized eye with extensive subconjunctival hemorrhage, total hyphema, and a low intraocular pressure, with a strong suspicion of a posterior globe rupture. The visual acuity was perception of light with an inaccurate projection. He was taken up for surgery, globe exploration under general anesthesia. After 360-degree conjunctival peritomy, we noticed a zone 3 circumferential scleral rupture in the superior temporal quadrant, about 9 mm from the limbus, between the insertion of the lateral rectus and superior rectus. There was uveal tissue and vitreous prolapse at the wound. The conjunctiva, subconjunctival tissue, and tenons are separated from the edges of the scleral tear, and the scleral tear was then sutured with 7-0 vicryl interrupted sutures, avoiding any incarceration of uveal tissue. A prophylactic segmental scleral buckle was placed to support the rupture site. 2 mattress sutures with 5-0 ethibond and a number 279 silicone tire was placed, and it covered the whole extent of the wound. This is the second mattress suture anchoring the silicone tire. Then the surgery was completed by closing the conjunctiva. On the 10th postoperative day, he was taken up for the second surgery with retina. Preoperative B scan showed dense vitreous hemorrhage. In a case of a dense post-traumatic vitreous hemorrhage, visualization is difficult, and you should start with clearing the thick layer of blood from just behind the lens prior to proceeding with the vitrectomy in the mid-vitreous cavity. Slow debulking of the vitreous hemorrhage was attempted layer by layer from the anterior vitreous going posteriorly. However, midway through the surgery, as we continued in the mid-vitreous cavity, there was continuous ooze of fresh blood, probably from the proliferation at the wound site. Fluid air exchange was done. Vitrectomy was performed under air. A part of inferior retina started to get visualized after we performed a fluid air exchange and increased the IOP to stop the oozing internally. However, since there was continuous oozing in spite of such maneuvers, we decided to stop the vitrectomy. We decided to stop proceeding further. So after multiple fluid air exchange, 20% SF6 gas was injected and the ports were closed. A repeat surgery was done 2 weeks later, and this time we decided to remove the lens because there was a thick sheet of blood just behind the posterior capsule. Phacoemulsification was done and the eye was left aphakic, and we performed a 23 gauge vitrectomy. Multiple layers of dense clotted blood was removed layer by layer, and the technique that has to be adopted in a post-traumatic vitreous hemorrhage is different from that of a normal vitrectomy for a vitreous hemorrhage. Here we have multiple layers of clotted blood, and we need to slowly dig inside layer by layer. Visualization was better this time. As we proceeded with the debulking of the clots, we slowly could visualize the retina in one quadrant. And once this is achieved, further surgery becomes easy. The underlying retina was detached with multiple breaks. All the breaks were identified. All the visible tractions over the breaks were removed. Peripheral skirting was performed as much as possible. The fluid air exchange was done, and the retina got flattened. Endolaser barrage was given around the breaks and all over the visible periphery. The retina was settled, and silicone oil injection was performed. Post-operatively, the patient is doing well. The vision has improved to counting fingers at 1 meter 4 weeks after surgery. This is the post-operative photograph showing a well-attached retina.
One minute, Dr. Girdar.
Thank you. Over.
Thank you very much for nice cases. Guess we'll move on right now. We'll keep discussion for later. We have to move on to Dr. Hassan Dibi presentation. Dr. Hassan, please, you can go on. Dr. Hassan, you are muted. Thank you.
Good afternoon, everyone. I would like to share with you my case, and just a few minutes, Dr. Paulo is presenting the case of some macular hemorrhage related to age-related macular degeneration. I am going to present the case in the opposite side in young patient with occlusive vasculitis that suddenly presented with some macular hemorrhage. So what is the submacular hemorrhage? It is an accumulation of blood between the neurosensory retina and the retinal pigmented epithelium arising from the choroid or retinal circulation. It is usually could lead to irreversible photoreceptor damage, stripping of photoreceptors outer segment due to contractions of the blood clot, and might be associated with toxic effect of iron, and it might have establishment of diffusion barrier between the RB and neurosensory retina. The etiology is variables, and among the most common causes are choroidal neovascularizations, either from inflammatory or even though from the age-related macular degeneration. Any surgical procedure could be associated with some macular hemorrhages, penetrating ocular trauma, ruptured retinal artery, macroaneurysm, sickle cell disease, necrotic tumors, optic disc trousing, coagulopathies, and central retinal vein occlusion. If you look for this case, it is rarely to have one patient with occlusive vasculitis that having some sort of some macular hemorrhage. The management, as mentioned by Dr. Paulo, it might be variable by non-surgical, just only by observations, which showed variable outcomes. And the factors that could be associated with poor visual prognosis in these cases: presence of choroidal neovascular per se, thick subretinal hemorrhage, age-related macular degeneration causes large hemorrhage. And the good visual outcome is possible in selected cases with very thin layer of subretinal hemorrhage. The management could be advanced nowadays with using vitreous anti-VEGF agents, photodynamic therapy in selected cases only, and we have the pneumatic displacement surgery by injection of expansile gas from positioning for several hours, then followed by face down positioning for 3 to 4 days. Surgical removal of some macular hemorrhage could be with TBA or without, even though the advantage of tissue plasminogen activators decrease the fibrin-mediated photoreceptor damage. Early lysis may allow early removal of hemorrhages and shorter duration of toxic effect of the iron from the blood to the retina. Some macular procedure trial, it's been in the past, but it doesn't show that the favorable result in most of cases, and macular translocation in rare cases could be used as an alternative. So the case is that I'm going to present is 17-year-old female presented with bilateral retinal vasculitis and branch retinal vein occlusions. Her vascular history was unremarkable, and her review system were as well unremarkable. Her visual acuity at presentation in right eye 20/20 and left eye 20/40 with normal intraocular pressure, and anterior segment examination showed quiet anterior chamber, clear lens. And the left fundus exam, as you see in these cases, we have obvious vascular sheathings with some areas of laser that apply to the area of non-perfusions. Investigation done thoroughly for this patient, including all the possible causes of retinal vasculitis, and ended by exclusion and the other types of retinal vasculitis. The patient were started on oral steroid, Cellcept, and as you see, the scattered photocoagulation were performed in both eyes. 2 months later, the patient presented with sudden loss of vision in her left eye for 7 days, with visual acuity of 5/200. And if you look for her, the left fundus, wide field fundus photography, you show that there is severe occlusive vasculitis with a patch of submacular hemorrhage in the sartan that lead to decrease tremendously the visual acuity of that patient. Her OCT shows clearly the subfoveal hemorrhage in the horizontal and vertical cutting. So the patient fluorescein angiography done and showed actually some sort of active vasculitis in both eyes, that not badly after the treatment, but because of the patient having some sort of collateral temporal to her left macula, it might be this is the source of the bleeding in this case. So the patient were taken to the operating room after discussing all the risk and benefit of the procedures, and the surgery were started with the core vitrectomy, as you see in this case. Core vitrectomy done. The patient as young as 15-year-old, and her vitreous is still strongly adhered to her retina. So core vitrectomy done, that being triamcinolone injected to visualize and help to create the posterior vitreous detachment, which was done easily in the case. Vitrectomy proceed until remove all the vitreous from the entire vitreous cavity. Some sort of visualization with add chandelier light to make sure that about the doing good procedure by injecting of TBA under her macula or retina, with applying of laser to the peripheral non-perfused retina. And as you see that we're starting to use 38 cannula at the superior arcade to inject 25 microgram on 0.1 ml of TBA, and that's injected severely, and avoiding to proceed to reach the fovea, as might be the blood clot adherent to the area with the inflations of the subretinal space with the TBA fluid that might lead to foveal damage or foveal or macular holes. So this is what's happened. As you see, the blip is nicely seen. Then air fluid exchange taking place. In addition to that, we inject the patient with Lucentis. In the same times, also there is no strong evidence based in this case, as there is no choroidal neovascularization, but might be there is secondary to occlusive vasculitis, we have perforation, so we augmented that with the intravitreal Lucentis at the end of the procedure. Further laser were done at the periphery, and then the case is closed of the sclerotomies. So this is her pictures after the surgery. The second day, as you see, there is gas, SF6, that filling around 1/3 of the vitreous cavity, and the retina seem nicely, and the blood, as you see, it's almost decreased and displaced a bit. This is her OCT, immediately post the procedure 1 week like, and you see that the most of the subretinal hemorrhages were not exist anymore. And this is here after gas that's been observed, and seen that nicely flattened retina. The visual acuity of the patient improved to 20/125/200 with establishment of that. This is her OCT angio of her eyes, and if you see that clearly in the one of the pictures that's down, there is collateral beside her fovea in the temporal part. So in this case, we are able to help this patient by immediate surgery 1 week after the sudden loss of visions. So in home message, time intervention is important in these cases. Leaving such patient with submacular hemorrhage, it might lead to permanent damage. And as this patient is a young patient, so we did our best, and we continued all the hair medication in form of immunosuppressive medication coupled with steroid. The surgery by itself is not that really tough surgery, but selecting your patient and doing your procedure, it might be an important to take a decision immediately as you see the patients. And as Dr. Paolo mentioned, these cases need really the timely interventions. Usually our windows of opportunity is around 14 days. And that's all, and I would like to thank you to give me this opportunity to present my case.
Thank you, Dr. Hassan, for a very nice case presentation and technique. We'll go forward with my friend, Dr. Madaf Rao. Hi, Dr. Madaf, how are you? You can go with your presentation, Dr. Madaf.
The mic, I think the mic.
Yeah. Yes, you are muted, Dr. Rao. The mic. Yes. Thank you.
I'm going to I have no financial disclosure pertaining to this topic. I'm going to discuss a couple of cases from post-trauma involving the posterior segment. Now, as we all know, ocular trauma is the major cause of visual impairment worldwide. Males are generally affected 9 times more than the females. Most victims are below the age group of 40 years, and most often it is work-related and it's industrial injury. We know this classification, it could be an open globe or a closed globe injuries. It could be having a laceration, a contusion, lamellar lacerations, superficial foreign bodies on one hand. On the other hand, it could be a penetrating or perforating with both exit and entry wound and a retained intraocular foreign bodies. Now, sequelae of injuries could be angle recession, hyphema, vitreous hemorrhage, retinal tears, and a detachment, subluxated or a dislocated lens, commotia retinae, choroidal rupture, macular holes, avulsed optic nerve, scleral rupture, and a foreign body, retained foreign body. Now, how to proceed? Each one of these cases are definitely different. It's not like a regular rhegmatogenous retinal detachment where we can plan, for a simple steps. No, they are going to be completely different from. So you need to put in all your experience behind, and you need to have often a multidisciplinary approach. You might have to call in a cornea specialist or a glaucoma specialist at times. No two traumatic cases are identical. I would present the first case. He's a 43-year-old gentleman. He is an engineer by profession. He was just lazing down on a Friday morning. He just wanted to do something at home, probably when wife said to fix the frame. He took a usual, chisel, a hammer and a nail, and he was fixing a frame on the wall. He noticed some kind of some foreign body entered his eye. He rubbed the eye and continued with his job. The next moment, he noticed that there is something still he could notice as a black dot. He went to an ophthalmologist. He said there is a foreign body inside the eye. The next morning, he presents himself to my hospital, and his vision was 1 part in the right eye, and the left eye was complete. His pressures were normal. If you look at gross examination, there was a minimal congestion of the anterior segment. If you go very close, there was a self-seed corneal wound at about 9:30 o'clock meridian in the mid-periphery of the cornea, along with a small iris wound. This was the OCTs as well, which was showing perfectly normal. You could see a small vitreous hemorrhage and a small retained intraocular foreign body in the inferior vitreous cavity. A point of contact at the retina has induced a small partial thickness, probably a retinal break and a retinal edema. So the diagnosis was very simple. We just wanted to document with ultrasound as well. Now, how do you plan such cases? His vision is 20/20. He has come the next day. Are you going to treat him conservative because his vision is 20/20? How do you time the surgery? Is it going to be immediate? And how do you justify that? Or are you going to wait for weeks? Now, counseling is very important in such cases because he has come with a lot of expectation. For him, he would say there is an entry of foreign body, you would just have to pick it up and bring it out. We know the difficulty of removing the intraocular foreign body. So explain him on the anatomical and the visual prognosis. There is always a possibility of post-operative endophthalmitis because of the retained intraocular foreign bodies. We might have to sacrifice the lens, a cataract in a young patient. So explain him about the loss of accommodation, a possibility of multiple surgeries. We would have done a good job, but they will end up coming back with a recurrent PVR changes. Complications of retained intraocular foreign bodies if unoperated, which can be an endophthalmitis and later on a cirrhosis. Now, this patient was counseled well. He agreed to go ahead with the surgery. We went ahead with the phacoemulsification. It was more or less the aspiration. Then we fixed the 3-piece IOL in the sulcus. Now, at this point, I would say, whenever you try to do such cases, either you can keep the eye aphakic initially, and try to bring out the foreign body through the corneal session, or you can probably enlarge as a traditional, case. Now I did the vitrectomy, the transflone induced. I'm inducing the PVD, continuing with the vitrectomy. You can see since the foreign body was very small in this case, it could have flown anywhere. It could have jumped onto the fovea or a macula. So immediately I noticed that it is moving freely in the vitreous cavity. So I covered the fovea with a bubble of LPFC to make sure that it is not causing untoward problems. And finally jumped onto the macula, as I was saying. So we did complete the vitrectomy, peripheral vitrectomy with as much as possible. You try to remove the base and the endolaser to the impacted site. Though it was a partial thickness, I prefer to do an endolaser. And we brought out the foreign body. In fact, I think the foreign body is, the way we brought out, it's not shown in, probably they would have changed the CDs. The gentleman, in fact, came back the next morning with a severe iridocyclitis, a thin hypopyon. So this is often the case. So you have to start them on a frequent topical and oral steroids and antibiotics as well. So his retina was attached. I reassured him. And this is about the subsequent follow-ups. He did well. And this is after probably a month. His vision was 20/20 with the normal pressures. A second case is a 42-year-old gentleman. He was referred with a penetrating injury and retained the intraocular foreign body. The referring doctor had actually done a CT scan and said it's quite a big foreign body. It was between the medial rectus and the wall of the nasal wall of sclera. So we knew it's going to be a quite large foreign body. It had also showed a corneal laceration, cataractus changes. This is how it was thought. So we planned for initial exploration. We wanted to tag the muscle, explore and suture the sclera, and then during the exploration, we wanted to bring out either externally or ab interno or external, the foreign body, because of the size of the foreign body. While exploration, I noticed that I couldn't find the route of entry. It was exactly beneath the medial rectus muscle. So I decided to put the cannulas on. Now what I noticed is, I tried to go in, the eye is collapsing. Now I brought it out, I said there is something wrong. I brought it out, the trocars, and again I refixed the infusion. And I tried to clear the vitreous, saying that let me at least hold the globe intact. I did it several times, I noticed it's not happening. Then I tried to do a lensectomy. I said, at least let me complete the vitrectomy. I tried to remove the foreign body. It did not happen. Finally, I had to disinsert the muscle and suture the point of entry at the sclera and stop the surgery temporarily. In the sense, I did the temporary tamponade with LPFC and came out without removing the intraocular foreign body in the first attempt. For the want of time, I'll go to the next. So when I retained with the LPFC, obviously you would expect them to come back with a severe inflammation. That's what had happened. The gentleman was coming almost every night in an emergency, complaining of severe pain. So his vision was always light perception. He was managed well. We waited for a week. We went in again. And this time, the vitreous had become like a membranes and had settled down on the disc. So I had to do literally peel the vitreous from the disc initially to induce the PVD completely, and did complete the vitrectomy. And then noticed tried to locate the foreign body. I went with with a intraocular foreign magnetic forceps. I tried to guide on the retinal surface. I couldn't notice. So what had happened in the last 1 week after the surgery, it had displaced downwards from being at the point of entry and causing a retinal tear. It had displaced down towards the optic nerve. This is the completion. This is the vitrectomy I'm showing still. Yeah, I'm trying to induce the PVD with the forceps. It had become like a thick membranes because of the LPFC retained for a week. No, I did the peripheral laser before picking up the foreign body. Once the peripheral lasers are done, I went back to the site of, and to my surprise, as I said, it was not seen there. I thought there should have been a foreign body. Then I used again a magnet to locate from internally on a attached retina, and then created a diathermy retinal break. I'm opening the conjunctiva to extend the sclerotomies to accommodate a larger gauge intraocular magnet. For the want of time, I'll show you I had to create a retinotomy separately after locating with the intraocular magnet. And that was a large metallic foreign body. You can see that it just pops out. And then with a handshake technique, I brought it out. I kept it on the capsulorhexis, and with the support of iris and the capsulorhexis, I decided not to make a further enlargement of the sclerotomies, and I prefer to bring it out to the anterior segment. I made a separate corneal incision. Enlarged it to accommodate the size of the foreign body. And then using a forceps, intraocular forceps, it was brought out, and we placed the IOL, a 3-piece IOL, and then further fluid air exchange and a silicone oil. This is how in the post-op period, and then after I left behind the oil for almost 6 months. Recently, I think in month of December, this is how it was seen in October. And this is how the OCT was seen. And in the month of January, after the silicone oil removal, is doing good.
One minute, Dr. Madaf.
Okay. So if you have, okay, this is about the third case. A 35-year-old gentleman comes with a blunt injury with open globe injury. He was sutured elsewhere. Primary suture was done elsewhere and referred to us with the counting fingers. This is how the eye was looking, with a soft, globe, corneal edemas, Descemet folds, iridodialysis, and a peripheral retinal detachment. We planned for a iridodialysis repair. And then did the usual capsulorhexis, fake emulsification, and I introduced the CTR, capsular tension ring, to keep the IOL in the back. And then after placing the, we went ahead with the vitrectomy. For the want of time, I'm skipping some anti-segment. So we went with the vitrectomy. What I noticed was here, he had a scleropateria and a significant attachment of vitreous in the periphery. You can see the lot of vitreous hemorrhage, especially in the inferior retina. And you could also see the inferior retinal detachment, a shallow detachment. In fact, it became a little larger while inducing while taking out the vitreous, adherent vitreous. So you encounter with all sorts of surprises when you are dealing with such cases. So he was managed with fluid air exchange, endolasers, and tamponade. So this is how the post-op pictures. He also did well. And a take-home message is you need a good clinical evaluation. You involve other specialties, the cornea, glaucoma, orbital, or strabismus specialties. A counseling with patient and their employers at times, they would come with employers as well. A meticulous planning and be prepared for all the worst possibilities, the unexpected on the following days. Expect multiple surgeries, often rewarding if the surgery goes on well. Thank you very much for the patient hearing.
Thank you, Dr. Rao. Thank you very much for nice cases. I guess we have 2 more presentations to come till the speakers join us. We can have some discussion by the panelists on the previous presentations. Dr. Faisal, if you have any comments on any, or Dr. Dogra, Dr. Matteo.
Fayed, you are muted. You are muted.
Yeah, thank you very much. And for the speakers, for the nice presentations. My first question for Dr. Hassan Dibi. Once you injected TPA, you injected it outside the arcades. Do you think that, is it, a good location to remove the subfoveal bleeding? Of course, in your slides, I saw that it was moved. Would you consider going inside the arcades with TPA injection? This is my first question. Yes.
Yeah, I think your question is really valuable in looking for how it, a little bit away. But if looking for this girl, she is young, her RB is really highly attached to her retina, and the clot of the blood, I don't know how much it was strongly attached to her fovea. So I'd like to avoid. The only thing that I was looking for the gas itself to do the job by rolling maneuvers over the macula, not just to detach the retina. So I'm sure that the TPA is going to be dissolved and lead to lysis of this clot. With the gas, it might be to the job, and that's what's happened to her, because I'm put her in the rolling position, in prone position first, and then in the face down and 30-degree every couple of hours. But to getting inside the macula, it might be this more effective for the gene therapies rather just only for the some macular hemorrhage. I don't know, maybe Dr. Who is presented just a few minutes ago, a case of age-related macular degenerations with Pablo. It might be help in such situations, because our experience with the AMDs is not that obvious. As you know that in the Saudi Arabia, we don't have a lot of patients. So injecting the TPA inside the macula, is it the same effective as the gene therapy, or should be at least at the arcade as I did? But if you look for my clip, it was huge. It's not just only small. So it's exceeding the superior arcade down to the mid of the macula.
Okay.
Dr. Dogra, you have any comment? Dr. Matteo?
Yeah, I have one good question, because Faisal may put a question here that I think is very important, because one of the problems to inject with the high pressure injector, because you are injected with the viscous fluid injector, is to make a macro hole. Then where is the best distance from the fovea to inject to avoid to produce a macro hole with the injection under the macula? This is a question for all of you, Hassan and Paolo and Faisal, perhaps you have experience on that.
I think what Matthew is saying has happened. Macular holes are reported, so one has to be very careful. And that's how probably a 41 gauge needle is being used, so that it is very, very slow. And that's so at this time, probably we don't get this complication as in past, because I think sometimes you can pop out a hole there, and which could be a serious problem. So my question was also to Paolo, is he only giving a fluid air exchange, or also injecting a gas like SF6 in the end, or all the time he leaves with the air?
Thank you, Manga. Thank you very much for this question. I fully agree regarding the risk of creating a macular hole when you are using the 41 gauge needle and you do inject very slowly, as far away as possible from the fovea. You try to avoid this complication. I usually tend to make a fluid air exchange with no gas, because I fully leave the eye with air, and I think this should be enough to displace the hemorrhage with TPA underneath the retina. But I think that putting SF6 might be an option in maybe cases where the hemorrhage is particularly thick and you want to have some longer action by the gas over the central retina.
Paolo, do you position your patient the first night?
Yeah, I tend to position the patient prone for some hours after the surgery, and then I ask the patient to stand in order to displace the hemorrhage downward. But for the first hours, the patient is put in a prone positions.
Thank you. Thank you. May I have a second comment for the trauma cases?
Yeah. I think one of the things I wanted to, sorry, Dr. Fayed.
No, sorry, just go ahead.
And so I wanted to ask Dr. Giridhar, also he put a buckle there outside on the, this is a through and through penetrating, the trauma is like gone out. So is it not better to do a vitrectomy and remove the hyaloid, because many of these cases, they'll ultimately lead to that intraocular sort of a fibrosis. So I don't know if Dr. Giridhar is there.
No, I mean, I showed two cases. In the first case, actually, if you see, there is no traction inside. So I thought that since the vision is 6x6 and this thing, I just put a small plomb, that's all. And that patient is doing quite well. There is no vitreous traction at the site of the wound. But as far as the second case is concerned, I have done a vitrectomy. So I did the vitrectomy as a second stage because there was total intraocular hemorrhage. So I did it after a week or 10 days. That's a normal practice in open globe injury. But I don't usually, as a routine, put a plomb before all patients with a posterior scleral rupture. It's not my usual practice. But in the first case, since there was a small tear there, I thought there is no harm because the vision was 6x6. It was there was no vitreous traction at the wound. So I thought we'll just put a plomb and then leave it like that. And he is doing quite well. And I have told the patient that in case there is any problem, you may have to go in for a vitrectomy. But the second case, I have gone inside and done a vitreous surgery.
Great. Dr. Fayyad, I guess you had a question or comment, then we'll go with the rest of the presentation.
Yes, I have a comment. I was surprised that nobody mentioned CT scan at time of trauma. I mean, if any patient walks into my office with perforating injury, the first thing that I would ask is CT scan. Not to have surprises. It has, you have dual benefit. First, if there is any intraocular foreign body. Second, you can localize the foreign body before going into surgery. I think I thought to make this point, to raise this point, because I think it's very important.
Yeah.
So
Point well taken, Riyadh.
all our cases had gone through the CT scan.
Sure.
No, I have a comment here. I mean, I think if a patient comes with a corneal, a large perforating open globe injury, where there is a large corneoscleral perforation, I personally feel that because sometimes there is a delay of about 12 hours for the patient to go and get a scan and come back with a report. So I don't think there is any harm in telling the patient that the scan is necessary. And especially when there is a total intraocular hemorrhage, we can repair the wound and then send them for a CT scan. So CT scan is mandatory. But then if you have a large open globe injury, which comes at the dead of night, patient has to go to elsewhere for a scan. I think that sometimes delays the whole, surgical procedure by nearly 10, 12 hours. That's very detrimental because that can result in infection and even loss of the eye. So I agree that the CT scan is very important, but in certain cases, we have to use our clinical acumen. And in certain situations, probably there is no harm, especially when you know you're not going to enter the eye now, and especially in cases where there is hardly any suspicion of IOFB. So
thank you, Dr. Redar. We'll go ahead with our next two speakers who just joined us. Please, Dr. Salam, you can go ahead with your presentation, please.
Yes, sorry, 1 second. Thank you. Good evening, everyone, and thank you. Great to be here. I'll share my presentation, share my screen. Right, can you see my screen? Okay, excellent.
Yes, yes, we can see.
All right, okay. This is a very interesting case. It's a diabetic vitrectomy, and then the case here started by our resident who is very much into retina, and in fact has a retina fellowship lined up very soon. So not very hyperopic eye or anything, putting the trocar here, one trocar put for the infusion cannula, second trocar going on. Trying to displace the conjunctiva, did not do that. And then here, the eye gets tilted. And then the trocar is there. We think it's all fine. But then we have, it's not a lens touch. It's actually a lens breach, lens capsule breach. So the question really is what to do with the lens. So we decided to leave the lens alone for now and then go for the vitrectomy. Fortunate enough, it was not a very difficult diabetic case, only a little adherence between the hyaloid and the retina, and the visualization was really very reasonable. So we finished the vitrectomy, and then we decided, okay, well, because the lens capsule is opened, now the fellow's taking over, then we'll do a phacoemulsification. If it was only a lens touch without the lens breach, we would have left the lens to another session, really, if it gets worse. But we thought the lens capsule is open. The cataract is going to progress so quickly, and or the patient will have really significant uveitis. And then here, hydrodelineation. We're trying not to hydrodissect, and here's the our fellow's trying to chop it, get a good hang on the nucleus. And then bringing the half up. And we were anticipating that the lens is going to fall. But again, fortunate enough, it's a soft cataract. And we already have the vitrectomy set up. Right, here's the rest, and then you can see by now, the capsule has extended significantly. And we're trying to stabilize the eye kinologue and vitreous in the antechamber. And then the vitrectomy from the front. Again, what I always tell the fellow, really, if you have a cataract and you leave some lens matter, fine. But if you have a complicated cataract with PC rupture, don't leave any lens matter whatsoever. And the reason is that we see all these cases coming from anterior segment surgeons, sometimes with inflamed eye after cataract surgery when it's complicated. It's not mainly the complication, it's leaving lens matter and not being able to clean well. So really, here we're trying to clean well and get every lens matter. So this part of the epinucleus will fall down, but then we focus on cleaning all the cortical lens matter and don't leave anything behind. And the trick really is to go very much under the anterior capsule. The pupil is getting smaller. I find intracameral adrenaline, even when the eye is open, very helpful. And the aim is to clean all the lens matter. Here, another tip is actually to drop the parameters down. So you will see here that the cutting is brought down. And that helps the removing of the epinucleus with the cutter. And now it's 3-piece lens in the sulcus, and all the cases done now by the fellow. And then we like to capture the optics so the IL power is not changed, and also you get nice compartmentalization between the anterior segment and the posterior segment. So I think several messages here. The main message really is be careful when putting the trocars in. And then the other message really is to, if there's a lens breach, I think that you have to remove the lens on the same time. You don't really leave the lens. If a lens touch only, then you may leave the lens. I just want to show some, just one more related thing here on the same topic. Is that okay? Are we good with time, or?
Yeah, sure. Can go ahead.
Okay, all right. Can you see my screen still, or no? Let me just, sorry.
Yeah, we can see your screen.
Okay. There's another video playing. Can you say that? Can you see that, or?
No, no video is
Okay.
playing.
All right. Sorry, give me 1 second. I think it's yeah. Share. All right. Can you see it now?
Yeah, sure.
Okay, all right. So this is a drop nucleus. I just want to show you my approach tree for these cases. And so it's a hard lens, vitreous. So vitrectomy, drop the lens down, no traction. And that's 25 gauge vitrectomy. And then here, this is actually what I do. This is actually 23 gauge vitrectomy. But this is what I do here in these cases. Is that I go through the limbus, and this is the phaco probe. This is the balancer tip of the phacoemulsification probe. I go temporal from the limbus, and the phaco probe is really nicely curved to accommodate for the torque that will happen in the eye. And then I just approach the eye with the phaco probe. it's likely a little bit tricky because of you're going through the limbus, but it works so well for me, really. And this is real time, just times 4, I think. So this is really unedited, except like it's spent 4 times. And the nice thing about it when you use the hyperpulse is that it remains attached very nicely to the tip. And it works really very efficiently, and you don't need to go through the sclera and open the conjunctiva and sclera. There's a bit of a learning part for it because the eye needs to be torqued a little bit, but I find the balance tip or the Kelman tip very nice because of its curve. It compensates for this. And it works so nicely. Then the important question really, would that burn the cornea? And if you remember at times like maybe 10 years ago, there was this question really, if you go with the phaco through the cornea, will it burn? And it does not really burn it. You just needed to make it a little bit larger than the phaco probe. And that's it really. And I really like that, and I don't open the sclera or the conjunctiva anymore. Thank you so much.
Thank you, Dr. Salam, for nice cases. We'll keep moving on. Dr. Qahtani is with us now.
Yeah, thank you. Thank you, Dr. Mohammed. It's a pleasure to be with you and all the team and the creative speaker. Can we start sharing the screen?
Yeah, sure. Yeah.
Okay. Okay, so I will present those cases within the time. And the first one is a Marfan syndrome. It's a 7-year child with a dropped crystalline and replaced by scleral fixation IOL after removal of the crystalline on the same session. So I start with pars plana vitrectomy like usual. Then I put the infusion always just to keep the contour of the eye. I do the section for the conjunctiva since I'm planning for scleral suture fixation IOL. I do cautery to stop bleeding sometimes, and I do the same things on the other side. Whiskered Caesar, of course, is very helpful because of its curvature and the blunt tip that it has. After that, I bought iris hooks because those baby doesn't dilate properly, and I find that most of those who has congenital problem doesn't dilate properly. This is the crystalline, crystal clear crystalline dropped on the pole posterior of the fundus. I do vitrectomy like usual, Kinacort multiple times just to stain the vitreous as much as I can, just not to miss any vitreous remnant. I try to grasp it by the tip of the vitrectomy itself. I don't use fragmentome because I believe it was soft and because the age of the baby or the child. So I decrease the cut to the minimum, increase the vacuum to the maximum. After doing good vaccination, a good vitreous vitrectomy and removing the vitreous, I can grasp it by the suction up and raise it and eat it up. I do PFCL to protect the posterior pool, and then I remove it. Usually, I like to do endolaser in those cases. As you know, the removing of the cortex of the vitreous is very important and having a good prognosis determinant. So I try to remove it either by grasp it or by scrape it. So I use the direct needle. This is the 8 Brolin needle. I use it in 2 points. The proximal one is the direct Prolene, while the distal one in each side is by the 26 or 27 gauge needle. This is the IOL designed to be scleral fixated. So I put the suture through the hole of the haptics. I put it through the needle, then I take it away. As you see, there is 2 holes in each side, and this is help to rotate the knot inside the eye later on. I do the same things of introduce it through the needle lumen, then I increase the incision. Usually it's 6 to 7 millimeter to accommodate this type of lens. You introduce it inside the eye, then make sure it's become behind the iris, and you suture one side when it's become centralized, then you suture the other one. just to remember it and not to forget that there is two holes in each side of the sclera. One of them is wider than the other. I rotate the knot to be introduced inside the eye through the big hole, which was done by the 26 needle, 26 gauge needle. After that, I just suture. Here I rotate it also in the knot inside the eye. I suture the cornea. I suture conjunctiva with the Vicryl 8 and removing the iris hooks, put some gas to protect the retina. And this is the first case. The last case is a trauma eye, actually. He's a 40-year Saudi patient who came to us with the right eye, complaining of a right eye central retinal artery occlusion. So we said we cannot do much in the right eye, but since you have a traumatic eye in the left eye since 20 years, maybe we can try to help in improving this condition. So because of this, an all trauma, and because of the calcified crystalline with severe anterior eye, I do temporary keratoplasty. I remove the cornea and I use viscodissection. Viscous injection is very helpful in inflating the eye. Also is very helpful in dissecting, soft dissecting of the tissue. I sometimes use scissor whenever there is a need. I'm trying to dissect a very fibrosed material, very calcified material that you cannot remove it by vitrectomy. So this is why I try to open the capsule by the cystotome. Then I try to deliver it as we do for extra capsular cataract surgery. I try to remove it smoothly without forceps, so I don't apply a lot of pressure on the base of the retina. I try to remove whatever I can by the vitrectomy, but whenever it's become very difficult, I use the scissor to remove it. Viscous injection is very helpful. It keeps the eye inflated, avoiding any hemorrhage intraoperatively. Then those fibrotic calcified material has been removed, inflating the eye, putting the temporary keratoplasty temporary to perform and to complete the vitrectomy. As you know, the suture should be always partial thickness of the cornea, not to cause any damage to the endothelium. Opposing technique with the temporary keratoplasty or with the real graft should be considered to get a good centralization. Unfortunately, when we go inside the eye, we see a very ischemic retina, very pigmentary changes. It's looked like retinitis pigmentosa. It is not, because the other eye was normal. This is a chronic inflammation of the eye since more than 20 years. So after removing the vitreous, I thought there is no need really to do endolaser because it's already very atrophic, very adherent. So I removed the temporary keratoplasty. Then corneal graft has been done. It's always wise to put a difference between the recipient cut and the graft 0.5 millimeter, just to have a good sealing. Opposing suture technique is very important. Partial thickness should be remembered always. Then rotating the knot always inside the eye. And this is the surgery was done and removing the sclerotomy. I think for the sake of the time, I'm not go more. So we would like to thank all of our organizer and modulator, and ready for any question.
Thank you, Dr. Abdullah, for a nice couple of cases. I guess we have 7 minutes for discussion of the cases presented. Dr. Dogra, Dr. Matteo, Dr. Fayad.
I think Prof. Matteo has something maybe.
I wanted to ask two things. First, about the phacofragmatome, the fragmatome to use in the vitreous cavity. The problem is that even you don't burn the cornea. The problem is that you enter very vertical, then you promote astigmatism, and then visualization may be a little bit distorted. And to Abdullah, I want to mention that in a Marfan syndrome, perhaps this guy is very young. and then to use Proline 9 or 10-0 in 10 years, perhaps you can have a breakage. Have you considered to go to Gore-Tex or to use other more, long-standing suture? And these are my two questions.
This is a beautiful comment, Prof. Carlos Mathieu. Actually, I was keeping the previous comment to give it at the end, but you always, the earlier, I always believe in fragmentome is much easier and safer for the retina rather than pulling with vitrectomy. It's just because this case is a soft crystalline. We all know that the fragmentome is the first step. If you don't have a fragmentome, you can use the phaco tip. And if I'm going to use the phaco tip, I will use sclerotomy also, because to avoid any astigmatism. True, Proline studies show that it stays for 10 years. And I have already did glued IOL in those cases, and we follow them more than 10 years now for some cases, and with no any single dislocated with the glued IOL, which is almost like partial Yamani technique. It's not really Yamani exactly, but there is a glue and there is a tunnel in the sclera at the same time. So Yamani technique, I believe it will be even more stronger. But I decide because it's available and faster, and if it drop, I may change it later on. But it could be on other options also, like Yamani technique, glued IOL, or any other cases.
Thank you, Dr. Abdullah. I have a question for Dr. Salam, if he is with us, regarding going through the limbus with the phaco probe, the Kelman probe, and don't you think that by going through the limbus and widening the corneal incision a little bit, this you are compromising the this closed system and pressurized system of vitrectomy when you do this, rather than going through the sclerotomies? Dr. Salam, are you still with us?
I don't think he's here anymore, Dr. Muhammad.
No.
Yeah.
I think
Matthias, comment or?
No, it's fine. Fine. But your question is the same. I did. I prefer sclera for sure, because less astigmatism. You distort the cornea so much. Perhaps you don't burn it, but it's a great thing. He did it and it was perfect. And
Yes, I may enter to that. I agree with you, Carlos. Using the phaco probe to get inside the vitreous is not designed for that, even though it could be done. But actually, it is a large. It's not pinned very nicely to get in. Sometimes, the particles of the lens, it might be floating, and then you have to go to look for it. So it is difficult. I think so. The fragmentome is very well designed and can help to do a lot. In the same times that when you have some residual, cortex at the pole of the lens, it might be difficult to catch it with the phaco probes. So I think it is okay if you don't have the facilities at that time, it might be used. But actually, I think fragmentome probe is really good, and to avoid any burning, because we don't know at what stage that could be happening with low and high grades. Back to Dr. Abdullah, I have one comments. I think the Marfan syndromes people, they have very thin sclera, extremely. Doing Yamani technique, it might be sometimes is not that the best ones, in my opinion, because putting the tunnels, it's an easy, usually it's very thin and it might be ruptured. I'm sure that Gore-Tex is the best. Proline, usually I saw cases that after 10 years, the IOL is being tilted or even that subluxated. So using Gore-Tex is the best for them. Avoiding, I saw that, Abdullah, even that you did some lasers when you are doing vitrectomy. Is that prophylactic, or you seeing something in the at the periphery of the retina?
Thank you, Dr. Hassan, for this nice comment. Actually, I do endo laser with every complete vitrectomy that I did, just for security things. Sometimes we do a pulling through the base of the vitreous, and this is cause some holes that I don't see it. So I'd like to be secure in those cases. And I agree with you, Gore-Tex suture is much better because of two reasons. Number one, degradation longer than the Prolene. Number two, it's easy to tie. And number three, whenever you rotate it, for example, if you have, as I did, the 2-hole, you can rotate it easily inside the eye. While the Prolene, if you decide to use it, you should go with 8 or a bigger size, like 8, 7, 6, just to make sure you don't cut it, because rotating the Prolene is very sometimes fragile. You can cut it after you already finish everything.
Thank you, Dr. Abdullah. We have a couple of minutes. Any more comments or questions for the speaker?
There is one question from the panel, from the audience. It might be Paul answering this regarding to intravitrial TPA injections. When you compare it with the subretinals, is still that could be used? This is, I think, questions from from the chat.
Dr. Paul.
This is a very good question and comment. When TPA was originally proposed, some authors suggested that TPA can be easily and simply injected into the vitreous cavity, and someone has shown that it is able to pass through the retina and do the job. So that's one possibility, but remember, when this was proposed, technological and techniques for vitrectomy were much different from today. Today we have transconjunctival 27 gauge vitrectomy, so the procedure is much less invasive. We have the 24 or 38 needle to inject TPA subretinally. We don't need any retinectomy to inject the TPA. So I think there's been a great refinement in our techniques, so that I would suggest that the standardized technique is to inject TPA subretinally and reserve vitreous injection to a minority of cases eventually.
Thank you, Dr. Paolo. And I think we come to a conclusion of this great retina session with our great speakers and panelists. We'll go straight to Vortex Symposium with Dr. Ashish Tiwari, who I guess he's with us right now.
Yes, I'm here. I'm here.
Yes. Hi, Dr. Tiwari. How are you?
Hi there. Thanks, everyone. I'm here also with Mike Fanning, who is CEO of Vortex, and also Carlos Manjes, who is one of our international reps. So I'll actually have Mike Fanning start off the presentation with a few words about Vortex.
Excellent. Good afternoon, everyone. And thank you for the opportunity, the organizers of the 2021. Hopefully everyone can see my screen. Is that right?
Yeah.
Yes.
Good. Excellent. So I want to thank the organizers of this meeting, the QOIC, and certainly MarVisions for the opportunity to introduce the panelists and the rest of the meeting attendees to our exciting little project based in St. Louis, Missouri. What a wonderful session moderated by Dr. Awadallah previously. A lot of talk about subretinal access. Really enjoyed the session, and it very much coincides with really where Synergetics, our previous company, and where Vortex has truly aligned itself as we begin to build our business out for years to come. Vortex Surgical was initiated in 2015. We started Vortex Surgical very much after the conclusion of the acquisition of Synergetics by Valiant Pharmaceuticals. And truly, as we looked for a way to continue to drive innovation in the marketplace, I was afforded the opportunity to assemble an assortment of different employees, and most of whom were employed by our previous organization. And it gave me the opportunity to really focus on three primary things: our people, our processes, and our products. As we look at the team that's been created and established at Vortex Surgical, we have 160 years of very deep knowledge of surgical retina. The team, as I flow through them here very quickly, most of whom have been working together for a long time and a number of years. Some of the technology that the panelists and or attendees may be familiar with includes photon, an assortment of different multifunction fiber optics. All the engineering team that worked with us previously in our organization has now formed the core innovation group at Vortex Surgical. So what's really paramount to us is truly people. When we put our team together, we looked for ways to put that group together, surround them with the best possible processes. We feel very strongly that if we have great people, we give them predictable, repeatable, measurable processes. What that yields is high quality, highly predictable, and high performing instrumentation. And when we really looked at the platform for all sorts of surgical products, we took a unique perspective at this. We had spent years in the operating room hearing doctors say, you know, this would be great. I would be great if you could make an adjustment here or there. Well, we've listened. And in the course of building out our products, there's a lot of reasons why we differentiate ourselves from both a performance, a quality, and a patient outcome perspective. So with that, I would like to turn over the rest of the presentation to Dr. Tewari, who is, we're delighted to have as our Chief Medical Officer at Vortex Surgical. So thank you, Dr. Tewari.
Thanks, Mike. Thanks, Mike, for your kind words and also your great leadership. So it is a pleasure to be here with all of you, and we appreciate getting a few minutes to talk at the QOIC meeting. And products are really what Vortex is focused on, innovation within products, and it's one of the reasons that I think that it's a company that's really exclusive within the vitreoretinal surgery space. And the other unique part of this is that we have a great relationship on the surgeon side with Vortex company from design and implementation of a lot of the products. And that's something that's absolutely critical, as you know, as you're active in the operating room, but something that's unique within the VR space. So what I wanted to do is just spend a few minutes just to go over a little bit of an overview of some of the products that are out there. It ranges from a premium line of disposable instrumentation with our disposable forceps line, specialty cannulas, which is actually quite appropriate considering some of the presentations from this session at subretinal TPA. So I have some videos to show about that. We also do customizable convenience kits where you can have a forceps, a contact lens, different cannulas that are customized to the individual surgeon. And then one of the other products that just recently launched is our Max Reach disposable laser probe. And I'll touch on that just very briefly. So the 27 gauge Max Reach laser probe, it's actually something I'm very excited about. We were just chatting in this session about 27 gauge surgery and some of these cases. This just launched in the United States and actually is also available worldwide. And we're getting great feedback and reviews from a lot of our 27 gauge surgeons. It's industry leading in what we call true 90-degree peripheral access. So I've loved using this probe. And in fact, I think for retinal detachment cases, it comes in really handy. That was always a little bit of a concern with 27 gauge. Can you reach in the anterior spaces of the retina? And you can reach all those spaces easily with this Max Reach laser probe. So this is something that I think is going to become, you're going to hear more and more about this, but it's a wonderful tool for 27 gauge surgery. One of the other instruments that we wanted to highlight is our line of Actuate forceps. And we can go ahead to the video and I'll show you this video here. I was lucky enough to work with some of our engineers here at Vortex to design this forceps. And what's unique about this forceps is that there are 8 individual levers that are built into this handle. The handle design is something that's very different from what you have used on the market right now. And these 8 individual levers allow you to get what we call 360 degrees of actuation. So thus the name Actuate is a sort of clever name for the handle. But it gives you that precise control when you're reaching and grasping for any membranes. This is a case of a macular hole using brilliant blue dye, where we can use the forceps to grasp that ILM very, very gently and safely. So it's a highly responsive forceps, but the handle design and a lot of the tip designs that we have for these are absolutely innovative. So we'll move on to our next product. This one that we're very proud of and is timely in when we're looking at subretinal delivery of different things, whether it's medication or gene therapy, or also in looking into stem cells. It's called the Nano, what it's called the Nano Vitreoretinal Subretinal Gateway Device. We work with Dr. Tamer Mahmood, who I think many of you know, and in designing this this product. And this is, when you look at the schematic there, it is something that you can use with or without vitrectomy. So that's the nice part of this. It allows you to access transscleral using a 30 gauge needle, and within that needle there is a 42 gauge subretinal cannula that you can advance manually. And we'll move on to the video here. So this is a case that Dr. Mahmood is doing. You can see he just has a chandelier in place and goes transscleral. This is a subretinal hemorrhage, which he is injecting TPA through that 42 gauge needle. And then here he's doing an anterior chamber paracentesis, and then injecting in about 0.5 cc's of pure SF6 gas. So this is subretinal TPA being done without vitrectomy. So this device we're particularly proud of. We feel like it's innovative in the space, and also looking forward as we see more and more clinical trials going towards gene therapy. I think that this is going to be a tool that'll come in quite handy. And the final product that I wanted to highlight is something called the Todorich Illuminated Depressor. So this is also a neat device, which you can see here is a little sheath where we have the light probe put in. In this case, this is the Alcon constellation light probe, and it allows you to illuminate this little bulb right at the edge. And now with the lights off, you can see a good amount of illumination that's coming out. So this is something that can be used for external transscleral illumination. So in this case, Dr. Todorich has got a pseudophakic retinal detachment, and he is trimming down the vitreous that's right next to the retinal tear. We've gotten great feedback and success with this product, also available everywhere, but especially for surgeons who are operating by themselves. If you don't have a resident or a fellow, this tool comes in quite handy. So this is just a little snapshot for a couple of the tools that we're working on. I'm really proud to be a part of this organization. I feel that the connection between innovation and the surgeons is something that is not on the market right now. And so with that, I just wanted to hand it back over to Mike Fanning, who can talk to you a little bit about contacting any of the organization.
Absolutely. So thank you, Dr. Tawari. I've put up among the screen here an opportunity to share our contact information. We are currently expanding distribution outside the United States. We are delighted to have Jose Carlos Mañez to help us build our international distribution. Carlos may be familiar to several participants. He is based in Lisbon, Portugal, very well traveled, very sophisticated, and very anxious to help any of you interested in learning more about Vortex products can reach out to Carlos or myself. And we are delighted to have Marvision as our distributor within the UAE for the time being. So with that, I'll turn it back to Dr. Awadallah or answer any questions from the group. Thank you.
Thank you, Mike. Thank you, Dr. Tawari. I guess we don't have any questions from the audience. Any of the comments from the panelists or speakers?
So I think it's okay now. There's no question from our attendees and panelists. Maybe we can.
Thank you very much for this great session and symposium. and we'll come to a conclusion of this surgical Retina 3 and this wonderful conference. Wish you a pleasant day, everybody. Thank you very much.
Thank you, Dr. Al-Wadal. Thank you very much.
Thank you.
Thank you, Dr. Tawari. I know.